Everyone to today's webinar, How Virtual Care Can Enable a Better Approach to Inpatient Psychiatric Care, Two Health Systems Journeys. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. If at any time you don't see your slides moving or you're having trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. And with that, I'm pleased to welcome today's moderator, Dr. Tom Milam, Chief Medical Officer at Iris Telehealth. Thanks so much for being here. I'll now turn the floor over to you to begin today's discussion.
Great, thank you very much. I appreciate you all hosting and appreciate our guests joining. And I know we've got a lot of people joining virtually. We've got a great crowd out there that have signed on to listen to this, either audio or being a part of the virtual experience here in our webinar. And I'll introduce our guests in just a moment, but really grateful for everybody taking the time out of their day to be here. I'm the Chief Medical Officer at Iris Telehealth, been a psychiatrist for over 25 years, and have seen a lot of changes in the landscape of how behavioral health is delivered in ambulatory and acute care settings. But it has really changed in the last 10 years with more telehealth options, and then certainly with the pandemic and where we are now. I would say that in my lifetime as a physician, I've never seen more change and more positive change on the Department of CMS, DEA, and other folks involved in shaping regulatory reimbursement modeling and things like that to help support people in underserved areas, rural communities, folks struggling with addiction, substance use disorders, mental health, just getting much greater access. And telehealth can really enable that across all service lines. So great to be here with you all today. I'll just show this first slide, Elson, if you could move to that. The next slide up there. At Iris, like many partners that do behavioral health, we love what we do, we have a heart for it, and we work across a continuum because that's where the patients are. We try to go to them in their journey. And if there's one lesson I would say that I have learned through doing telehealth well before the pandemic and then during it and now afterwards, I would say one of the biggest changers is that the patients and their families are our customers. And I know it's not a term we use a lot in medicine. We say patients or clients or something. Customers was a hard term for me to grasp, but the reality is that's a good term for them. They're able to shop for healthcare options. They're able to have choices for where they go for care. And it means that all of us that offer care need to be on our game and really learn about what the patient's needs are, how to support them in their journeys, and how we connect to them rather than expecting them to come to us. The bricks and mortar days, we still need bricks and mortar facilities, but they were prohibitive for many people. The drive, the gas, the cost, the time off from work, so many reasons why there's no shows or people going to the emergency room to seek care because they had to. And we shouldn't penalize or vilify patients for doing what they need to do to get the care that they need. Our job is to listen to that journey and what we've experienced over the last several years and before, and then say, moving forward, how can each of us in our health facilities work to meet patients in that journey and sort of let go of how we've conceived it in the past and embrace a new way of seeing that. So putting patients in the driver's seats. I also think the other big thing that I've learned, I think will come up today, is how do we keep patients well between appointments? Not just making an appointment when they leave an inpatient unit, but do they fill their medicines? Do they have problems? How do they connect back? What if they can't fill their med? There's an issue. What's their side effects? How do we handle these situations? Virtual care, digital health, these other technologies coming in are going to be really game changers for helping patients stay well between appointments and after acute care, post-acute care. And many of the people here on these teams are involved in that discharge planning and follow-up process. So It's exciting to have everybody here today to talk about this. So you can see the continuum from inpatient, med-surg, consults, all the way down to ambulatory and working primary care integration. It's an exciting time, not just for Iris, but for many folks that are working hard to get care to patients suffering with substance use disorders and mental health issues. Next slide. Just have 2 quick slides before I introduce the folks that have given their time to be here today. Virtual care on inpatient units. So I'm going to look at it from a staffing perspective and then from a provider perspective. And that fits with our folks that are on today because we got 2 providers, psychiatrists that provide care and a psychologist that provided care, and 2 people involved in leadership and shaping and running inpatient units. So we're going to hear from both sides. I'm excited about that. Staffing challenges, I'm just going to throw out some basic ideas around that. First is that inpatient care is still quite desirable. Recruiting for it can be challenging. And some cities have no problems recruiting, or some areas are just lovely to live in, and others are very challenging. They have wonderful communities, but it's hard to recruit. So we see a lot of heart. A lot of people love their units, love their communities, but have challenges recruiting providers. And that's everybody from psychiatrists and nurses and nurse practitioners down to folks to help with environmental services, room turnover, things like that, food services. Staffing challenges are very real. Secondly, virtual care providers do provide an access to a larger pool. So we see folks trying to recruit for who's coming to our town and who's living here. And I've seen amazing things for the abilities to recruit people locally in communities. When you work with an organization like ours, we're pulling together providers that are potentially from all over parts of the country. And so you have a wider pool of very, very talented people. And we, like other telehealth companies that focus on behavioral health, really try to curate excellent providers that have a heart for the work, the missions, the community. Even though they may not live there, does not mean they don't have a heart for the service and patients in your communities. So that's something we're learning, that just because you're virtual doesn't mean you're not engaged in the well-being of that community and those patients. So that's kind of a myth there. Unless you're on site, you don't really know people. It takes a little longer to get them all the services, but you can be very engaged in with the teams there, and it's a lot of fun. The hybrid approach works well, where we're working along on-site people, and sometimes they're out sick, we can fill in. Sometimes there's a snowstorm we can cover. So there's a little more flexibility with telehealth. Sometimes we get hurricanes and lose power as well. It's happened this week to some of our providers. So there's challenges there, but working together with folks on site is very meaningful. We're not here to replace anybody. This is about hybrid care and making sure that patients have access to the providers and the level of providers they need. And then virtual care also really helps with building out your on-call pool. So sometimes you can get people to round during the day, but covering weeknights, covering weekends, rounding on weekends, being on call, triaging, working with staff. You got to have all that throughput from EDs and outside referrals and transfer centers. So that can be really meaningful, where you can build out your pool of people that are in that call who are also then working on your unit and helping out in various ways. So those are some of the staffing challenges and the ways I think that telehealth has sort of mitigated some of those over the last few years. I think the last slide I have here is about the providers, working with inpatient providers. I do find that traditional models, an attending psychiatrist comes in and he or she or they round on their team, and that's kind of the way it is. But there just aren't enough psychiatrists, and like many other specialties, behavioral health has learned to leverage psychiatric nurse practitioners successfully. I mean, who among us hadn't gone to see a physician, OBGYN, or primary care, and we're not working with a PA or a nurse practitioner? So why is that different in behavioral health? There's a lot more opportunities from just excellent nurse practitioners to gain certification in psychiatric mental health nurse practitioners, and training programs and experience. And so we've had fantastic ones, some in ambulatory setting, but some really like acute care, consult liaison work. So being able to get them working to full license and to have that team approach, working collaboratively, and we've leveraged that at many partners and is very meaningful. Providers, some say, oh, they can't do everything. Well, I would say, what can't we do? Even physical exams. I mean, I can't look at range of motion on a knee bending, but I can watch somebody else do it. And increasingly, we're able to do stethoscopes, look in people's ears, all these things virtually that are becoming possible. So some of the barriers are breaking down, but some of the physical assessment issues are more challenging. Just about everything else that we can do. So some say, oh, you can't do an AIMS score, you can't do certain things, you can't watch everybody gait. I'll say, yeah, you can. Come work with me for a day and you'll see. You can do all that stuff, and you and your team working together. The ability of providers to move across different geographic regions is really important too, so that you might have different facilities in different areas, and you have providers that are driving around. It's not doing that. Doing it virtually is better environmentally. A really great study just came out recently on the environmental impact of virtual care and reducing carbon footprint, and tracking that over the course of the pandemic, saving billions of dollars by not traveling and other ways that are just more green, doing virtual care, so that you can move around facilities. Laura will tell you, hospitals here in Roanoke and then one 30 minutes south, and it's a drive. Sometimes I'll drive, sometimes I'll do virtual work, sometimes the weather decides for me. So, and even if you have COVID, you can still see patients because you're not there on the unit. So there's that ability to geographically extend yourself virtually is a real plus. And as I said, there are not many things we can't do. Physical exams, some limitations there, but most other things that where there were troubles, like checking people that are in seclusion or restraints, where back in my day, you had to go in and put your fingers in each of the straps to make sure they're not too tight. All those kind of things that now can be delegated to other staff, and that being an important thing to free up providers from having to go do that, or having to call a hospitalist who's in the ED saying, hey, can you come over and put your fingers in these straps and check on this patient for me? We've worked through all those. So a lot of good things have happened during COVID that have leveraged virtual care. And so I think it's kind of settling. It's settling from a financial standpoint in terms of the return on investment for investing in virtual providers. And it's settling clinically in terms of the true experience that you can have virtual providers at a very meaningful part of your team. And they're not secondary to on-site. It's just different, but they can work collaboratively, and it's a lot of fun on meaningful work. So with that, I'm going to go and I'm going to quickly introduce our panelists and then start asking them some questions. And in the meantime, encourage our audience to submit questions, and I'll have those teed up to me. So if you could go to we're already there. Next slide. So got Laura Taylor here she's Program Director of Psychiatry at Carilion Clinic and Carilion Newburgh Valley. So Laura, thank you for being here. James Anderson, who is not co-chief, he is chief of the Department of Psychiatry at Bassett Healthcare. And then glad to have James here. Really enjoyed our partnership there and getting to know their team and working with lots of areas there. Tisa Yuso, working at Bassett, and psychiatrist. Really wonderful to have you here. She's somewhat new to that organization, but has really helped develop and shape these programs. And some of these are new, cutting edge stuff where people are trying virtual care for the first time. And then Ganzar Khan, glad to have you here as well from St. Mary's up in Maine, and just shaping some new models of care there with how you do 7 on, 7 off, 14 on, 14 off, all sorts of things where telehealth and virtual care allows for greater flexibility. So thank you all for being here. And I'm going to jump right in with some questions, but feel free to say a little bit about yourself before answering some questions. Let me go to my list here, because I've got some really thoughtful questions that have come in from others and also some myself. Laura, and for you and James, just starting on the partner side, just a general question there. Over the last 3 years, early COVID until now, what have been some of the biggest staffing challenges on your inpatient unit, and what have you found so far that's kind of working or not working, or What have you learned that would be some insights you want to share with our audiences? Laura, how about you?
Sure. Thank you so much, Dr. Milam. And just a friendly reminder to reintroduce myself. I'm the Program Director of Inpatient Ambulatory Psychiatry at Carilion, New River in Virginia. We are in more of a rural location, so we often experience our own challenges outside of the traditional setting in a more established city. I've been in my position for approximately 2 years, and one of my primary responsibilities is the oversight of our ACPs and coordination of our physicians who provide care on our inpatient psychiatric unit. More generally, I oversee multiple departments and align with established goals by Carilion and the department. So going back to your question, Dr. Milam, some of the challenges, I entered into the department in the midst of COVID. We had one provider who was on site, and then we had several providers who were coming into the unit to provide care. I had an opportunity to work with one of Iris's physicians for an established period of time. Most of the problems that I saw really were trying to navigate the call-outs. We had patients who tested positive for COVID. We had to shut the unit down, reopen the unit. And it really took a lot of time to kind of navigate scheduling to make sure that we were staffed appropriately to meet the patient needs on the unit. From a hiring standpoint, we were waiting for physicians to complete their credentialing, and it took many months for that. So to have an established Iris telehealth provider was incredibly important because it created reliability on the unit. We knew exactly what we were working with when we had that physician, and she was very reliable, and it just created continuity of care.
Thank you, Laura. I appreciate that. And James, how about you and so what you all have experienced there at Bassett?
Sure. Thanks, Tom. So I'll follow Laura's lead. So I'm James Anderson. I'm a clinical psychologist by training, and I'm now the sole chief of our department. The confusion is because I was initially appointed as a co-chief. And I've been doing this by myself for about a year. Bassett is located in a beautiful area of upstate New York, but not unlike what Laura is describing, we're pretty rural. And there's at least two factors that come along with that. That means that our patients are spread out. It means that certainly in comparison to the part of New York that a lot of people imagine when they hear that name, we've got folks that are struggling with low socioeconomic status, and we've got a challenging payer mix. Coming along with all of that, it can be tricky to recruit to this area. So the question was about the last 3 years. I think, given that I've been in this role for just about a year, I'll have a little bit of a shorter window in my answer. When I came in, we had a few factors that were kind of some headwinds as we were trying to keep the department running. We had a very successful and longtime chief of the department who retired after more than 2 decades with us at Bassett. And we had along with her a very stable and long-standing core of psychiatrists that were all essentially part of the same cohort. And when the chief made her decision to step down, many of her cohort decided to retire at about the same time. We had a sort of early and unexpected exit of my co-chief, whose role was to really be in charge of the inpatient side of things. And so when all of those things happened together, we had a shortage of clinicians generally, but really acutely on the inpatient side. And we're in the process of trying to rebuild our clinical staff, and we're actually seeing some success there. But we can't bring people in fast enough to meet the really significant and important need on the inpatient side. And so when we came across IRIS generally, we had some experience throughout the pandemic with doing virtual visits, not just within behavioral health and psychiatry, but generally throughout our hospital system. We'd been doing that for the past 3 years. And it became clear to us as we were experiencing both some of the benefits as well as some of the challenges of using locums, in-person locums, to run our inpatient unit, that we needed to come up with a intermediate to long-term solution that was going to be, at least for now, almost exclusively our way of providing physician oversight on our inpatient unit. But we also thought that in the long term, it was going to create a situation that we could offer more flexibility when we were looking at full-time staff members, when even if they weren't working full-time in a virtual capacity, that they would have that tool as part of their tool belt. So whether it was because of illness or because of convenience or what have you, it's just a really important arrow in our quiver to be able to expand virtual health to include providing services on the inpatient end.
Well, thank you, James. I appreciate that, and you're really thoughtful in terms of the staffing challenge that you all faced. And turning to Tisu, to you and Gunsfar, in terms of being psychiatrists, like me, you've been a psychiatrist a long time. You've worked bricks and mortars, acute care, ambulatory, all sorts of settings. What kind of led you to get into virtual care, both personally and professionally to begin with? And what's the journey been like for you in terms of what your life is like now versus what was like in person, both the pros and cons of that? And Tisa, how about we start with you?
Sure. Excuse me. Thank you for having me, everyone. And I'll just briefly talk about myself. So my name is Tisa Ayuso. I've been working with IRIS Telehealth since about March of 2023, and came on to work with Bassett in December of 2023. So we're very new working together, but I think it's been fantastic thus far. And in answer to your question, I think the pandemic really got me thinking a lot about telehealth and how much I liked it, how much it was convenient to see the patients, to have them come in for appointments. When the pandemic started, I was working at a brick and mortar at a Greenwich hospital in Greenwich, Connecticut, and we went virtual very quickly, and it was pretty easy to get the technology up and running, and the patients loved it. And I just felt it was really a natural, easy transition. I started thinking about doing telehealth full time. One, for personal reasons, because I had moved from Greenwich, Connecticut to Hamden, Connecticut, and my commute was becoming absolutely crazy. So I really thought fully about making telehealth a full-time opportunity for me. And I'm glad it worked out and it was successful. So the convenience of working from home has really been fantastic, I think, in terms of, saving on gas and maintenance of my car, and my husband loves it. So it's great because he works from home as well. So it's worked out, I think, really well. And IRIS has been really fantastic. I have a fantastic team that I've worked with since I've started. And again, working with Bassett has really been really nice. Dr. Anderson has been very, very supportive. Like he said, this is a new position in terms of this virtual medical director position. I'm actually an interim medical director for now, and I think it's gone really well. We have our systems in place in terms of our morning rounds. We have the computer system up and running. We recently just got a fish lens type of camera, so I have a better visibility of seeing everyone in the morning meetings, which has been fantastic. They also now have recently got a speaker, so they can hear me a lot better. And so we had a little bit of growing pains because initially I was using some Bluetooth earphones, and that wasn't working very well. So I have now these better earphones. And so, things are working, I think, very well in terms of the technology. And in terms of availability, we have a system going in terms of the rounds. And then we have initially we had not pushback at all, but really figuring out who was going to take the computer to where I needed to see patients. We had to figure that out. And recently, just this week, I started working with medical students. So we now have 2 medical students on the unit, which has been really, really nice. They are lovely. Two medical students, and it's a Bassett Columbia program. These students are from Columbia, but they choose this Bassett program, and they really wanted to learn more about rural health, and learn about does a lot of they do a lot of work with continuity of care and things of that sort. So I'm really excited to be working with medical students as well. So, again, when I was at a brick and mortar facility, I worked with medical students. So I think this is fantastic that I can continue working with, medical students and teaching them and things of that sort. And that has worked very well. We use the computer system, and we figure out times when we can sit and talk and chat and talk about patients, and they have an ability to write notes. So we have that ability to kind of converse about that. So it's really, I think, worked very well thus far. It's only been, today's the 18th, so it hasn't been that long of January. It's been about a month now, but I think things have gone really, really well.
Oh, yeah. No, that's fantastic. Thank you for sharing that. And Dr. Khan, how about you? Just personal and sort of professionally workflow. How's it been in your role?
Thank you, Tom. Good afternoon. So my name is Gazanpur Khan. I'm based out of Florida, and as Tom said, I served a hospital acute psychiatry distance one. But to answer your question, I've been in brick and mortar or in-person provider for the last 12 years, doing inpatient and outpatient practice. And then I have been with IRIS since August of 2023. I was inpatient, in-person provider till February of 2023, and I was a medical director. I was because of the shortage and everything, like you mentioned, I was almost working 7 days a week, and it was not very healthy personally and for my own mental health. So when I tried to cut down, as again, there's not enough providers, I had some resistance. So I stepped down from my medical directorship. Even then, it was a resistance from the hospital. So it was not by my choice, but also I started looking, and then I found, I can say I stumbled on IRIS. Then I talked about the model, and it seemed promising, 7 on, 7 off, inpatient, like hospitalists we have been seeing them doing for decades. There's not much of psychiatry who does the hospitalist model of 7 on, 7 off. So it was since I moved in August, I can tell you that it's been very encouraging for my personal health. And then on a professional end, I can say that yes, there was some reluctance on my end to do all telepsych. I've been able to do some telepsych for the past 10 years, but to transition all to the telepsych in basically at a psychiatric hospital, it was a transition, but it was a very encouraging and kind of enlightening transition for me. I see that as, again, it's not only an adjustment for me, it was an adjustment, like, prior speakers have talked about, adjustment on the culture of the hospital, on the culture of the organization. And we are able to move from a traditional model to more intuitive or dynamic model, I say, because it's ever changing with all the new innovations in AI, in the technology. That's why I call it more dynamic model. We are still learning from our experiences. I'm still there 6 months on, and I think every day or every week we have been making progress, and if we do have any issues, or we're able to do the problem solve. So I think professionally I have been able to focus more on patients rather than my driving 30 minutes or an hour one side. So spending 2 hours of your driving just on the roads. I've been able to focus more on my patients. I have charts pulled out when I'm seeing patients, so I can see their labs, I can see their medications, I can see nursing, social work notes, so everything in collaboration. It has been working great for me. Very quick transition for me, and it was very helpful, but I think the hospital staff made it more convenient for me to transition from the in-person to the virtual provider.
Yeah.
Thank you.
Well, thank you all. It's really helpful to hear. I wish I'd kept track over the years of how many hours were saved where people didn't have to commute anymore, because it's really an ambulatory setting, people commuting hours, sometimes 2 hours each way, and that's time back with family or personal time. Might be listening to less books on tape as we're driving or podcasts, but that's a real gain. It's amazing how far people have traveled, particularly in rural and underserved areas, to reach out and connect. Laura knows I'm 30 miles or so between here and our hospital down in Radford, and it's on a road that seems to always have traffic or accidents and whatever. And so I grew up on this road, and I just fear it sometimes of having to commute down there. But most of the time it goes okay, but it is nice to do it virtually as well and have that blended model. Laura, let me ask you, just in terms of patients' experience and also staffing experience, what have been, again, pros and cons of telehealth? What have been some of the challenges that, or pushback, or certainly we think, patients say, I want to see a doctor in person. I don't want to see him on a screen or something. But what are some of the feedback that you hear, both positive and negative, full picture in terms of patient and staff?
I think overall, it has really enhanced our patient care to have the blended model. I had an opportunity to round with our telehealth psychiatrist for a period of time, and rarely would I hear patients request a different provider. This provider was very good at building rapport quickly with patients. They exchanged a wealth of information back and forth, and I think patients felt very comfortable with that provider in a telehealth setting. In fact, I don't know if I can recall a time when a patient had requested a different provider. As far as the pros, I think that our social workers who are assigned to our physicians, whether they're telehealth or in person, picked right up. We had an iPad that we would take around. Our social workers would support that process and were part of the rounding that occurred with our telehealth psychiatrist and the patients. And it was almost seamless. Outside of, if we hit a technical glitch on occasion, if there was weather, or I know one of our providers enjoyed meeting in a particular group room, and if there was rain and we have a skylight in there, we would hear a little bit of feedback. And so we would have to navigate that and find a different place or a location. But those are very easy things to overcome. And in the grand scheme of things, our patients put just a ton of positive information on their discharge feedback and on their summaries, giving positive praises to the telehealth psychiatrist. She had provided a tremendous amount of support to them. And it was overall, I think, a fantastic experience. It does take a little work on the telehealth psychiatrist side to establish those relationships because you are not in person. So having conversations, reaching out to the social workers, spending some time with the assigned nurses who are assigned to those patients, as well as collaboration with the psychiatrists who are on the ground here is very important. I know that our telehealth psychiatrist also had a very close relationship with our assigned pharmacist here. And so they would often be in conversations back and forth, discussing medications and other patient needs where she needed a little bit more consulting work. So overall, I think it was very a wonderful experience. Our physicians really enjoyed our telehealth provider. They worked collaboratively together. And I think, too, it really prepared us as a system to pivot very quickly. Not only were we dealing with COVID and the effects of COVID, but also after COVID, we're still coming up with other medical issues with patients with the flu and with, post-COVID exposure and things that are happening. And to allow our teams to already be in line with offering telehealth and to pivot very quickly, it is a very seamless transition, and we are able to meet our patient needs very quickly and not have a gap in care.
Well, that's great to hear. I think we've heard the word culture several times, and I think it's been a word that I've used in that understanding what is the telehealth culture. It wasn't a question we asked really before COVID because there was essentially no telehealth culture. It was very infrequent, sometimes audio-only therapy or something. But nowadays it is, what is that culture and how is it embraced, both from the staffing level, but also from an organizational level? I know some people have asked questions about long-term. Is this temporary, or is it truly viable long-term? I don't know, James, I know it's been somewhat new there, but you've also, your experience in this space. What, in terms of the culture there, things that you faced patient-wise, staffing, and then leadership-wise, tell us a little bit about that journey there at Bassett and the changes. Sure.
So the challenges that we've experienced so far, as Dr. Ayuso said, I mean, granted, it's only been about a month or so, but I've heard exactly 0 complaints from patients about the care being provided on the virtual side. The challenges that we faced were really sort of on the front end, making sure that we were ready to go with a style of care provision that is new to that unit. It's not, like I said, it's not new to Bassett, but we have never done it before on the inpatient psychiatry unit here at Bassett. And a big challenge was regulatory. So being here in New York State, there are a lot of hoops that we have to jump through to even have permission to provide services through telemedicine. And so that was probably the biggest challenge, was going back and forth with New York State and getting a hold of the right people and making sure that we checked all the boxes that they were requiring for them to amend our operating certificate to allow us to provide care in that manner. And then I wouldn't say that it was really a challenge so much as there were legitimate questions and concerns from staff on the unit about how we were going to operate on a day-to-day basis. I think Dr. Ayuso mentioned there was this concern about how are we going to get Dr. Ayuso into the room? And it turns out that that wasn't as big of a deal as I think some people had anticipated. In terms of the benefits, I can tell you this might be news to Dr. Ayuso, but I assume it'll be positive news. I just got an email today from our clerkship director, who's in charge of he's a psychiatrist, and he's in charge of the medical students' psychiatry rotation. And, so this is the first time that we're doing that using a virtual psychiatrist. And he wrote back saying that the students are having a fantastic experience, that they love Dr. Ayuso, that there has been absolutely no barrier to her being remote. And in fact, in some ways, there's some suspicion that there's even more contact with Dr. Ayuso than there might be if the psychiatrist was just there in the unit because of the necessary back and forth through electronic communication. So it's been positive with the students. I think it's been sort of a pleasant surprise to some of the staff members on the unit about how non-disruptive it has been. Of course, there's been some growing pains in terms of equipment, making sure that we get the right sound system, the right visual stuff there. But those are solvable problems that we've been able to navigate. And I think having this proof of concept has been really good for the organization. And I think it makes it a little bit easier when we are going out and we're trying to recruit to an area where it's not always easy to recruit to. And we can offer a sort of a hybrid setup where if you are taking this job, and yes, there might be shifts that you have to do on the inpatient unit, it's okay if we set those up to be virtual. And we should also mention it's not as though there is no in-person presence on our inpatient floor. All of our nurses, including our nurse manager, are there in person. Our social workers are there in person. We've got psychiatric nurse practitioners that are there in person. And so we do have much of our staff who is there in real life. And then we've got Dr. Ayuso as sort of the head of the team who is remote. But so far it has gone honestly even better than I could have expected. And some of that is due to the technology, and I have to be honest. I think a big part of that is we got a really good doctor in Dr. Ayuso, and so that counts too. Whether it is virtual or in person, you got to get the right person, or it doesn't matter if you're doing it brick and mortar. If you're doing it virtually, you need both the right temperament and the right skill set. And we're really happy to have you, Dr. Ayuso. So
Thank you.
That's what I would say.
That's really nice. Extra praise here on this webinar. It's wonderful. You all raised some interesting concerns and issues about doing it, because we in our minds we have this workflow of you come onto the unit, you see patients, but having done this work for 20-some years, rounding and all, I didn't always hang out on the unit. I would come in and round, maybe have students do some teaching, but then you got other stuff you got to go do. You got to we got consults to do. You got clinic in the afternoons. So the actual time on the unit wasn't like sometimes a lot. Just hanging out, just sitting in the nurse's station, just waiting. You come in, you see patients, you do stuff, you have your team meetings. What has that been like for you? Dr. Yusuf, we'll start with you again, just in terms of how your interaction with the staff has been and their receptivity, their flexibility. Do they need to be more flexible, or do they all have to become tech experts now on sound systems and stuff? Or what other supports are built around to help with those, whereas things you wouldn't need if you were just walking on the unit?
Sure. Excuse me. Yes. Excuse me. Thank you, Dr. Anderson, again for those kind words as well. And, I think like Dr. Anderson said, there was a little trepidation, I think, from the staff in terms of, okay, how will this work? I mean, from before I came, there was a set time that rounds would take place from 9:15 to 10. Generally 10, sometimes it runs over if there's, some discussions about certain patients. But for the most part, we have that time period. And then, generally what I like to do, I prefer to start seeing patients right after we finish rounds. We usually talk. There's always 1 to 2 nurse practitioners on every day. Currently, right now, it's just 1 nurse practitioner. The other nurse practitioner is out. So myself and the nurse practitioner, we talk as a team in terms of how we're going to split up the patients. We usually do that. And then we go and we see patients. And like I said, now that we have the medical students, we all go as a team and see as many patients as we can until about 12, because at 12 o'clock, I usually give the medical students a break. But, that varies in terms of the time and such. But always before I sign off with, the medical students to take a little bit of a break, I always touch base with the nurses. We always touch base and, here's what we spoke about with this particular patient that you're carrying for the day. These are the patient's concerns. We discuss making medication changes. So we have that close contact throughout the day in terms of, patients and things of that sort. And I just wanted to piggyback on something too, in terms of, I saw a question in there about the legals and how that all works as well. So part of our rounds in the morning, we make sure that we have our unit clerk speak about legals. If there's any legals that are due, if there's any, legal, those type of things. We try to incorporate that into the clinic meeting so that they can send me over the paperwork and we could get that signed and such. We're still in the process of figuring out DocuSign or some sort of other system in terms of making an electronic signature. But at this point right now, we're just kind of scanning the paperwork, sending it over to myself in a secure setting because I'm secure here, and, making sure I'm getting it back to the unit clerk so they can put that in the chart and such. I mean, I think that's been the only challenge, I think, so to speak, in terms of, can we do something with DocuSign or something like that? But we're figuring that out as we speak now. But, I definitely spend a lot of time speaking with the nurses, with the nurse practitioners. Once a week, I'm meeting with the one nurse practitioner who's on the unit now. We're meeting weekly on Thursdays around 4 o'clock. We're trying to meet for 30 minutes to 45 minutes to kind of touch base, for the week. That being said, I touch base with her, every day. And sometimes if we need, for instance, if, I think it was last week, she had some difficulties with a patient, and she said, "Is there an opportunity for us to speak?" I said, "Oh yeah, I can call into the system at 4 o'clock, for instance." So I try to be very, very flexible throughout the day in terms of my availability. So it's not just those rounds that I'm on the camera. We pretty much talk through the day, and during that time, I'm working on notes and getting through things as best as I can. But I try to be very available, which helps. I think helps in terms of people feeling comfortable.
That's great. It's great to hear. I think that's you just put your finger on something of trust, and that team members can trust it. Just because you're not in the building and maybe in some office where they could come find you doesn't mean that you're not available.
Sure.
And Dr. Khan, I wonder if you could speak to that too, in terms of you find the trust for a virtual provider, that there is some, are they really going to be there, or are they not going to log in? What do I do? Where do I go? I can't find them. They're in another state. Or do you feel like you have to work harder at checking in with nurses and social workers and other team members so that they know that you're there? Because I know our motto isn't just pop in around and leave. It's being available. Yet we do have to write notes and other things. So how is that sense of trust of virtual providers, particularly in that kind of that culture of introducing virtual care where it wasn't before? What's your experience been like?
Thank you, Tom. So I would say it's about any relationship. We are going into that relationship. They are new to it. You bring in the technology issues on top of it, and then your provider not being in there. So even as a new in-person doctor, in-person psychiatrist, nobody trusts you until you build that relationship. After you build that relationship, then the nurses know they can contact you even 7 o'clock in the evening, because that doctor responds, or 5 o'clock, and some of them don't. So you don't change the personality of a doctor just because they go virtual versus in person. So once you are in that relationship, initially you have to invest in, and yes, it is an investment on the provider end, because we are sitting there, and all the other units of the hospital are on the other side. So there is no one-to-one interaction like 3D interaction, I say. So once you build up that relationship, it's a work up front. But like any investment, if you put the work up front and the response time, when the staff sees you responding in time, they have, basically HIPAA compliant messaging system. You have it on your phone, you have it on your computer, you're sitting computer doing your work. I agree with you. In the hospitals, you would go in and you would round, and after the round, you would not hang around the unit. The staff would text you, call you, or communicate with you through other means. The same way it is now. It's just initial investment as a new person going in, and them also going into a new relationship, not only with you, but also with the technology, but also with the new, like I said, the dynamic structure changing from the traditional. Once you build it up, once it is there, then everything is streamlined. The communication is easy. The coordination of care is easy. You do the treatment teams in the morning. Everyone understands. And regarding, the emailing or the faxing of paperwork, it's all become part of that day onwards. And it's not as overwhelming as it seems like it. It becomes everyday process, and every day it gets better and better. Thank you.
That's a great point. We all can just think back a few years from when like having a hearing for a patient, or forms being signed, medication consents or treatment plans, where you'd sign, someone come find me, hey, I need you to sign these. We can't do that. Even recently working with a partner where there were like 10 hospitals in their system, and 6 of them said, oh, we need wet signatures. And I was like, how are you going to get wet signature for a form that you need back in an hour? It's just not possible. We can't mail it to you. What do you really mean, wet signature? Or you just, what they meant ultimately, what we discovered, they just mean not a Xerox signature. You can do DocuSign, but you can't do we also call it Xerox copied. You know what I mean? You can do DocuSign or something that's legitimate and not just a copy of the thing. So some of the legal challenges, regulatory. I'm going to move into just a couple of questions because we've got about 9 minutes left, and I've been trying to weave in the contents of multiple questions from the audience. They're fantastic questions. Let me just, so for for James and you and Laura, can you say anything about why you chose like Iris as a partner? I'm not trying to just promote Iris, but I'm saying some places say, hey, we can do this on site, we can build this out, and that's great. And at Iris, we've helped organizations build it out or help carry it for a while and transition back to them. What would you say in terms of what people should look for in a partner if they're thinking about getting an outside vendor or organization like Iris or others to do behavioral health? What are some questions they should be asking or looking for in partners? So Laura, James, I'll throw that out to you too.
I can go first, Laura, or yeah. So, I mean, there were a number of things that we considered. One was ability to become impaneled with our various insurers. We absolutely want people that are willing and able to accept Medicare and Medicaid, and so that was a big one. I think a willingness and ability to provide collaboration, both sort of on the ground, as Dr. Ayuso is describing, with our nurse practitioners who are physically on the unit, and then eventually legally as well, serving as the collaborating physician for our nurse practitioners. And then also, I think we looked at a handful of other companies, and I don't want this to sound too much like a sales pitch here, but what stood out for us when we were talking with Iris was really, on top of those other things that we described, it was really strong communication and project management to help us. We kind of came in and we sort of knew where we wanted to get to, but we didn't necessarily know how to get there. And Iris had this sort of combination of knowledge and kind of commitment to clear and confident communication and willingness to collaborate, but also having some proven ideas that had worked before. That was a big plus. And then I think the clear commitment to quality of services, including making sure that when Iris is presenting a clinician to us, we know that clinician has already been really well vetted by Iris. And there's a bit, by the time we're actually talking to a clinician, there's a little bit of a halo effect that comes because we've built this trust based on other elements of our sort of building up that, it's not like we would just take somebody sort of sight unseen, but there is kind of that halo effect that comes across. And as we build the partnership and we see that things are working in other areas, for us at least, it made it a pretty easy choice to go with Iris, and we've been happy with it so far.
Thank you. And Laura, I know Iris has partnered with you at times for years for an inpatient person. We do consult liaison work and multiple different hospitals. What's that journey been like in terms of what you would recommend people think about in partnering with a telehealth organization or thinking about that?
I want to echo what was just said. I think the relationships and communication are incredibly important. Working with well-informed individuals that know exactly what to do, have had that experience, and can offer solutions while also listening to needs. I think that's been one of the main things that I've enjoyed so much about my relationship with Shannon, in kind of figuring out what Carilion needs, how Iris can meet those needs, and being creative and thinking outside of the box. She is always willing to have conversations, to think about different ideas, asking a lot of questions, and really having nice dialogue about what Carilion needs and what Iris is able to offer. I also think the ease of transitioning a provider into the Carilion system is flawless. Every need is thought of, every detail is thought of. when it comes to invoicing, when it comes to just general back-end operations, everything is very streamlined, it's predictable, and there are no surprises. So I think that it's just been a wonderful experience and is meant to support Carilion and Carillion's needs and not create barriers. Great.
Well, thank you. That is great to hear. And the issue of trust has come up several times. And so the last couple of minutes, Gunsfar and you and Tisa, if you could say to organizations that are maybe on the fence and they have beds that they would love to open, but they haven't been able to because they haven't recruited and they're trying and they really want to keep trying, but they're thinking about leaning in towards virtual care and having a virtual provider come on. What would you advise them in terms of how to approach that and what the experience could be like? Dr. Khan, why don't you speak to that? Or Tisa,
thank you, Tom.
You can go Dr. first. That's
okay.
No, go ahead. You go.
Okay. All right. Sorry about that. So, yes, I think as human beings, we are very comfortable in our traditional model, the way we are, and we don't know the benefits of something until we try. As if, again, as a regional medical director when I was, you close the doors and then you close the doors to progress. If you're not ready to change, if you're not ready to take a risk, a limited, calculated risk, which others have taken and paid off, you can piggyback on it and give it a try. And I have seen benefits on both ends. I think that is the future for all the underserved communities. And Tom, you mentioned, the closed beds, the beds we can't fill. It's not only because of the providers, it's because of the nursing. And I saw one question in there. So yes, there is a future in which not only, we will be able to do that, but we will be able to provide nursing care, through a lot of nursing care one-on-one. And there is a lot going on right now, which can be done in that aspect. I think the prayer was realistic. People are in need and we are turning them back. I think that is more of a humanistic liability on me as, in this profession than being able to provide a care which I don't think is the perfect according to my current standards now. That's what I see. I would think of it, giving it a try.
That's great. Thank you. And
yeah.
Tisa, how about you?
Yeah, I would piggyback on what Dr. Khan said in terms of, yes, definitely having a strong provider, right? So again, making sure that the provider is warm and empathic and has great experience, because I think that all comes through in the camera, in terms of nurses seeing that, providers on the floors or in the hospital seeing that, patients seeing that, just really picking a really good provider, someone who is invested and wants to, work with the organization. And, again, all organizations have different cultures and kind of learning those cultures, learning about how things work and, just kind of immersing yourself in it. I think someone had asked a question in terms of Bassett and how we're able to kind of talk so seamlessly with each other. We have and I love it. I wish I had this in other jobs. There's this great system called Tiger Text that we use, and it's a HIPAA compliant system, and we can communicate with anyone in the hospital, from nurses to nurse practitioners to medical doctors. If we're looking for a consult and we're looking to have that conversation with the consultant provider, so I think it's really awesome to have that real-time communication aspects of things. And I think it really works. People have to want to do it. I think, like you said, some people can be hesitant to do virtual care because, they might be worried about, will it be the same? Will you get the same level of service? And I think it depends on the provider, but I think, Iris has done a fantastic job in terms of choosing providers to work in these community settings. And it's a real need, and I think we're providing great service.
Yeah. Well, thank you. Thank you for that. And thank you to everybody for attending. I know our time is up, but this has been a rich dialogue and an ongoing one that we'll continue to have. And I appreciate the audience participation. We've tried to answer as many questions as we can, but it's been a really meaningful time. I want to thank each of our panelists for being here and taking time out of their busy days. And thank you all. I'm going to turn it back over to the Beckers folks to close us off.
Thanks so much. I'm going to echo the same sentiments. Thanks so much for the excellent presentation. And thanks to Iris Telehealth for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thanks for joining us. We hope you have a wonderful afternoon.
Thanks, everybody. Thank you.
Bye-bye.
Bye.